Okay, welcome everyone to our second What's New in Addiction Social Work talk of our 2020-2021 cohort year for Interdisciplinary Addiction Fellowship Program. My name is Cody Callan, and I'm the Director of the Addiction Social Work Fellowship stream at the BC Centre on Substance Use. And it is absolute pleasure today to have the opportunity to introduce Hella Lee. Hella Lee is currently an Addiction Social Work Fellow with the BC Centre on Substance Use. Prior to starting our fellowship program, Hella was working as a family therapist at Vancouver Coastal Health's Eating Disorders Program. She has also worked at the St. Paul's Hospital Eating Disorders Program as an individual, group, couples, and family therapist. Hella is particularly interested in the role of family in addiction and mental health treatment and how to effectively and compassionately engage support people in treatment and recovery. Today, Hella will be doing her presentation on examining secure care, looking at how we can support youth after a serious overdose. And I'm going to pass it over to Hella in a moment to do her presentation, but we will have some time for questions at the end. In GoToMeeting, there is an option to add questions as you go. So if you want to enter those at any time during the presentation so that you don't forget them, please feel free to use that question box liberally, and then we will do our best to answer all the questions at the end. I'll also come back on at the end of the presentation, and if anyone wants to share their questions verbally, rather than typing them into the question box, that will be an option as well. Without further ado, I will pass it over to Hella for her presentation. Thanks, Hella.
Thanks, Cody. So, hello, and thank you for joining me this afternoon. As Cody mentioned, my experience has been primarily in the eating disorders field, and I've really appreciated all the new learning opportunities that I've had in the Addiction Fellowship. In today's talk, I'll be examining secure care and how we can support youth after serious overdose. This topic particularly interested me as it's a really complex situation that we also face in the eating disorders field. How do we support a child or youth whose well-being and life is threatened by their disorder, even if they are not ready or willing to change? In the eating disorders clinic, it's not unusual for youth to be reluctantly and sometimes angrily brought into their first and subsequent appointments by their parents. Sometimes lots of parental pressure has gone into their child and getting that child into the first appointment. And that's where our work as clinicians begin, on working on engaging that youth and supporting them and their families along the scary and sometimes painful journey of recovery. I'd like to start by respectfully acknowledging that I'm a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And if you're calling in from other territories, I invite you to take a moment to acknowledge those territories as well. The learning objectives today are to gain an understanding of secure care and the proposed Bill 22 and their implications for youth in British Columbia, and be familiar with the arguments and evidence base for and against secure care and involuntary admission after youth overdose. In my presentation, I will review key terms, including secure care, stabilization care, and Bill 22. I'll talk about some of the services that are needed for youth struggling with substance use, discuss some of the arguments for and against secure care, and talk about harm reduction in youth. I also want to take some time to talk about readiness and motivation. I will talk about secure care across Canada, and in particular, what is happening in Alberta, and describe what is happening with stabilization care at BC Children's Hospital. Finally, I want to talk about our responsibility as clinicians in engaging youth and leave some time for questions at the end. First, I want to bring to light one parent's story that was posted on CBC in 2018. Brenda Doherty said she did everything she could to try to save her 15-year-old daughter's life, but gaps in the system designed to help youth struggling with addiction contributed to her death. Squamish teenager Stephanie Lawrence died of a fentanyl overdose on January 22nd, 2 days after she was released from Lionsgate Hospital in North Vancouver. Stephanie was taken to Lionsgate Hospital by police on January 20th, and her mother says she was released within an hour, despite having the Form 4, or medical certification form, already on file. I didn't even have time to get there, said Doherty, who was at home in Squamish. They even gave her the bus pass at the hospital to get back down to Vancouver. I want to present some data showing child and youth overdose deaths. This table shows illicit drug toxicity deaths by age group between 2010 and 2020. There have been 112 child and youth overdose deaths in the past decade, 17 in the past year alone. Currently, when a youth presents to hospital with an opioid overdose, parents or legal guardians are generally not contacted, nor is a teen admitted for stabilization, as the youth typically refuses to consent to either. Many teens are discharged after 1 or 2 hours of observation, often alone or with another minor. And many parents and care providers are calling for secure care legislation. But what exactly is secure care? Well, there seems to be no universally agreed upon definition. The term is used for services which include short-term crisis and substance misuse interventions, medium-term mental health services, and longer-term criminal justice interventions. When discussing secure care today, I'll be referring to the concept of involuntary admission or treatment of youth under the age of 19 who are at serious risk of harm due to their substance use disorder, without specifying a time period. Stabilization care is another term that's been widely discussed recently. Stabilization care refers to when a youth is admitted to the hospital, involuntarily if necessary, following a life-threatening overdose requiring resuscitation. This admission typically involves 5 to 7 days of stabilization, assessment, and detoxification. In addition, the goal is to support and engage the youth, notify parents and guardians, and facilitate community or residential treatment with an aim for direct transfer whenever possible. Bill 22 was introduced in the BC Legislature on June 23, 2020, and proposed amendments to the Mental Health Act, which would allow designated hospitals in British Columbia to establish stabilization units and legally authorize short-term involuntary stabilization care for youth with severe problematic substance use who present in an emergency department after an overdose. The youth would have had to receive one or more of the following: administration of overdose reversal medication, intubation and/or resuscitation or another type of health care to prevent imminent death. Bill 22 would allow a youth to be admitted to hospital for 48 hours of stabilization care, or up to 7 days if it takes longer for their decision-making capacity to return. The bill was not passed before the end of the legislative session in the summer of 2020. However, Bill 22 hasn't been the province's first attempt at passing secure care legislation, and it's unlikely to be the last. These efforts have been going on for over 20 years, starting with Bill 25 in 2000, private members' bills that did not move beyond the first reading stage, the 2019 Safe Care Act, which would have allowed a parent or guardian to apply for an apprehension order for a child or youth between the ages of 12 and 19 who is at risk of serious harm of being commercially sexually exploited or who is suffering from severe drug misuse or addiction. Which brings us to Bill 22, whose future seems uncertain at this time. And though we currently don't have secure care legislation, the Mental Health Act is sometimes used to mandate admission to hospital because of serious substance use disorders. And youth can also get caught in the criminal justice system. Data collected from the At-Risk Youth Study between 2005 and 2012 showed that among 1,019 participants, 36% reported having been recently incarcerated during the study period. So what's happening with secure care across the rest of the country? There are 7 provinces that have secure care legislation: Alberta, Saskatchewan, Manitoba, Ontario, Quebec, Nova Scotia, and New Brunswick have legislation for the involuntary confinement of young people at serious risk of harm. BC is the only large province that doesn't have secure care legislation, along with PEI, Newfoundland, and the 3 territories. What are some of the special considerations we need to take into account when working with youth? And what is unique about the adolescent brain? It's a time of significant growth and development. The brain does not finish developing and maturing until the mid to late 20s. Ongoing changes in the brain, along with physical, emotional, and social changes, can make teens vulnerable to mental health problems. The immature prefrontal cortex can lead to impaired decision-making and risky behavior. And exposure to drugs during adolescence can result in brain function impairment that can last into adulthood. On top of these developmental processes, we know that many of these youth have experienced trauma. According to a recent report by the Representative for Children and Youth, the first reason youth gave for using substances was to numb emotional pain. 86% of the youth who had a substance-related injury or death had experienced at least one trauma, and 100% of the youth in care had experienced trauma. Of those same youth, 73% had a confirmed or suspected mental health diagnosis. That number increased to 91% for youth in care. Add to that the effects of overdose. Acute intoxication with opioids, as well as other substances, can significantly impair a youth's cognitive and behavioral capacity. With all of these factors involved, and the crisis of the overdose situation, including experiencing withdrawal symptoms, the reaction to that distress is often to fight or to run. So, how do we help a youth who has come to the emergency department after a serious overdose? We know that the best way to support a youth who's struggling with substance use disorders is not just during points of crises, but it involves a comprehensive system of substance use services. And these include prevention, support for family and caregivers, and support for family connection whenever possible, residential and community-based youth substance use services, community and cultural connections, in particular Indigenous cultural connections, resources in rural and remote areas, and of course, harm reduction services. We need a comprehensive system of services and resources for youth. But what happens to those youth who fall between the cracks of our system? The demand for community mental health services for children and youth continues to exceed their availability. As of May 1st, 2020, over 2,500 children and youth were waitlisted for child and youth mental health services, and the average wait time was 53.9 days. Involuntary treatment should never be taken lightly, but can secure care help intervene in life-threatening situations of youth who fall between the cracks? Although there are some internal reports and opinion pieces written on secure care, I wasn't able to find any published peer-reviewed research on this specific topic. There are, however, several commentaries on secure care and the ethical debate, which I won't be going into today, and here are just a few, which I'll also include in my reference list. There's a lot of debate around secure care in the media and amongst care providers, policymakers, and parents. But what are some of the concerns? In my talk today, I'll be focusing on three concerns that I've heard frequently in conversations with people and through my reading of the literature and media reports. Increased risk of non-fatal overdose after treatment due to lower opioid tolerance. The fear that youth may be more reluctant to report overdose. And the question about whether involuntary treatment is effective. So let's start with a question about whether secure care leads to more overdose due to loss of tolerance after an enforced abstinence. Well, there is evidence to support that. In a prospective cohort study of over 10,000 adults who are using heroin and entered treatment, results showed that there was a substantially reduced risk of death during a range of treatments. And there was a higher excess risk of overdose in the first 30 days after treatment completion or cessation. And a study of non-fatal drug overdose after release from prison showed that adults released from prison are at high risk of non-fatal overdose, particularly in the first 14 days after release. And non-fatal overdose after release from prison was highly associated with a recent history of substance use disorder, mental illness, a lifetime history of injection drug use and non-fatal overdose, being dispensed benzodiazepines after release, a shorter index incarceration, and lower perceived social support. So will secure care result in more overdose? There is evidence to support an increased overdose risk due to loss of tolerance. However, with no intervention, there's also an increased risk of death after non-fatal overdose. Non-fatal overdose is a risk factor for subsequent fatal overdose. A prospective cohort study of people who inject drugs in Vancouver showed that of the 2,317 study participants, there were 134 fatal overdose deaths for an incidence density of 8.94 deaths per 1,000 person years. Reports of recent non-fatal overdose were also independently associated with subsequent overdose mortality in a dose-response relationship. A retrospective cohort study of patients 10 years old and older who presented to an emergency department at least once with non-fatal overdose reported that of the over 21,000 patients who presented initially with an opioid overdose, approximately 10% died over the subsequent year. Of the 419 unintentional deaths, 88% were due to overdoses, and 38.3% of these deaths were due to opioid or other narcotic drugs. In this retrospective cohort study of 4,155 patients, among emergency department patients who survived an initial overdose, mental health and substance use diagnoses were associated with a higher hazard of repeated overdoses, whereas opioid prescriptions and admissions were associated with lower hazards. And interestingly, there was not a relative increase in either methadone or buprenorphine prescriptions among those admitted to the hospital versus those not admitted, indicating that there may be other protective factors related to a hospital admission besides the pharmacotherapy aspect of medication-assisted treatment. People who survive an initial overdose are at greater risk of repeated overdoses and subsequent fatal overdose. And we know that harm reduction can save lives. And though young people are significantly more likely to report overdose in the past year, they're also less likely to know what naloxone is. Psychological distress, homelessness, or unstable housing and detoxification were also independently associated with increased odds of overdose. In a retrospective cohort study of over 4 million Medicaid-enrolled youth between the ages of 13 and 22, results showed that less than 1/3 of youth received timely addiction treatment in terms of behavioral health services, pharmacotherapy, or both, within 30 days of overdose. 1 in 54 youth received recommended evidence-based pharmacotherapy. The authors state that interventions are urgently needed to link youth to treatment after overdose, with priority placed on improving access to pharmacotherapy. However, a qualitative study of at-risk youth describes that many youth initiated opioid agonist therapy for short periods of time to mediate the discomfort of withdrawal during inpatient treatment. But adherence to medications like methadone and buprenorphine over the long term did not fit with many youth's visions of normal futures. And youth who did access OAT often preferred methadone because of its perceived ability to mediate long-standing physical and mental health issues. Given that data shows that few youth receive recommended evidence-based pharmacotherapy, and that those who do may only use opioid agonist treatment for short periods of time, youth who use substances are at substantial risk. And critics worry that secure care will result in youth being more reluctant to report overdose. There is no evidence to support that. However, there is research that shows that people are reluctant to call 911 if it can result in negative outcomes for themselves. One study described that a 911 call was often made in the absence of naloxone or when naloxone didn't work, but as a last resort. Reasons why they didn't call 911 included simply not having a cell phone, in which case they would approach a police officer for help or ask bystanders to dial 911 for them. And avoidance of police related to penalization, in particular, the occupation of abandoned buildings. This fear of police often deterred them from staying with the victim until the arrival of emergency medical services. An Ontario study of why people don't call 911 described that the vast majority of participants report having had negative interactions with police, which discourages them from seeking medical assistance at future overdose incidents. However, there are also other factors that influence a youth's experience of calling 911. A BC study of youth who had used drugs at least weekly and had encountered police in the past year reported that negative experiences occurred when police used their power without benefit to youth or were rough or disrespectful without care for the person overdosing. But that youth saw police in a positive light if they were compassionate, stepping aside for paramedics, or reviving someone experiencing an overdose. Youth also had very mixed knowledge of the Good Samaritan Drug Overdose Act and were concerned about criminalization if they called 911. And for those of you who aren't familiar with the Good Samaritan Drug Overdose Act, it became law in 2017 and provides victims or bystanders who call 911 protection from charges or possession of a controlled substance and breach of conditions regarding simple possession of controlled substances. We don't know if secure care would change overdose reporting patterns of youth, but youth would likely feel more inclined to call 911 if they felt that it would be a positive experience versus a negative one. How do we as care providers work towards making that experience one of caring and safety versus threat? I'd like to read a quote by a 17-year-old youth, which comes from the previous study. My current boyfriend, he overdosed. I called 911 and the ambulance came first, and then the cops came, and I was crying. I was freaking out, and they came and sat with me like, it's okay, it's okay. And it seemed like they really did care about me and my boyfriend's well-being, which I thought was kind of crazy because I'd never experienced that before. Negative interactions with police do seem to discourage people from seeking medical assistance at future overdoses, and police were seen in a positive light if they were compassionate. So, even if we did have secure care legislation, does involuntary treatment work? Well, this is a hard question to answer from the research, as there's a wide span of mandated populations that have been studied. I found several papers on legally mandated people, as well as college students, but none specific to this topic. In a paper which provides an overview of the key issues concerning legal coercion in substance use treatment and a critique of the research base, the authors concluded that 3 decades of research into the effectiveness of compulsory treatments have yielded a mixed, inconsistent, and inconclusive pattern of results. So I thought I would present a sample of some of the studies I've read. This study compared adolescents with no criminal justice system involvement, or no JSI, to justice system involved with or without being mandated, who presented to a private outpatient substance use disorder treatment facility. I chose to present this study as it looked at self-motivation versus external motivation to enter treatment as well. This figure shows the percent days abstinent on the vertical axis and the time in months from the first treatment session on the horizontal axis. Compared to the no justice system involved group represented by the bottom dotted line, mandated participants, represented by the dashed line, had a stronger initial response to treatment in terms of percent days abstinent, followed by a more rapid decline in percent days abstinent in the second half of the follow-up period. In this figure, showing log odds of heavy drinking, which is considered 6 or more drinks on one occasion on the vertical axis, and time in months from the first treatment session on the horizontal axis, JSI individuals represented by the solid line, and mandated participants represented by the dashed line, showed initial decreased heavy drinking that rebounded following treatment. The results around motivation showed that self-motivated patients did not differ from externally motivated patients on percent days abstinent or heavy drinking. And less than 2/3 of the participants who had no justice system involvement also reported an external reason for treatment entry. One prospective study of 40 alcohol-dependent patients admitted for involuntary treatment reported that 6 months after discharge, 25% of patients were abstinent and living in the community, and 7.5% had notably reduced their alcohol use. A total of 82% of this patient group were actively engaged with an assertive community treatment team. And finally, a prospective study of 202 hospitalized patients with substance use disorders who were admitted either voluntarily or compulsorily showed that voluntary treatment generally yielded better outcomes. However, the frequency of use of a preferred substance showed marked improvement for both voluntary and compulsory patients at follow-up. And the authors state that the alternative to compulsory treatment is no treatment at all, and instead a continuation of life-threatening drug use behaviors. Our observed outcomes for compulsory patients support the continuation of compulsory treatment. So, does involuntary treatment work? Well, sometimes, but there are mixed results. I think most of us would agree that people tend to make the most effective changes when they're ready and actually want to change. But how do we help people get to that place of readiness? In the eating disorders field, and this is likely common in many other areas as well, I've experienced this belief that people have to hit rock bottom before they're ready to change. And certainly there have been people who've shared their rock bottom stories with me and how that had motivated them to recover. However, other people have also shared that it's actually a false bottom. And even when they think they've hit rock bottom, they still fall further down. And often, the further they fall, the less able they are to begin to make those changes on their own. They describe that what once began as something they could manage and control ends up controlling them. In those situations, is the best we can do for these people to wait and hope? Well, sometimes that is the case. But in the context of children and youth with eating disorders, we access family and sometimes hospital support, voluntarily and involuntarily, in order to help refeed a youth to a stage where they are nourished and stabilized enough to gain mental clarity and hopefully be better able to engage in treatment in a way that's meaningful for them. Sometimes restricting autonomy can eventually provide youth with more of it. And we also know that the final rock bottom is tragically death. I'd like to take some time to talk a little bit more about motivation. What does motivation to recover actually look like? As clinicians, we may hope that our patients come to treatment feeling confident and empowered. But in reality, most people come to treatment with lots of fear and trepidation, often being encouraged or pushed by family, friends, employers, child protection, healthcare providers, legal coercion, and even contingency management. Because ambivalence is a normal part of recovery. People don't want to be dependent and suffer the negative consequences resulting from substance use, but they also don't want to let go of the effects of the substance. Substance use may be what helps them cope with painful emotions and trauma. It may provide in that moment some peace and euphoria that they may not know how to achieve any other way. Motivation is not a static condition, but changes in response to external and internal events. This is important to keep in mind because youth may hope for a different kind of future for themselves, but in moments of anxiety, boredom, fear, substance use may feel to them like the best option or an option that they can't refuse. And in situations where youth are reluctant or resistant to treatment, pressure from family and peers often plays a central role in initiating and managing substance use disorder treatment, sometimes by pressuring youth to begin or continue treatment. Pressure and support from parents can be pivotal to youth having the motivation to seek and enter treatment. This pressure can come in the form of ultimatums, having privileges removed, or rules imposed, being kicked out of home or being threatened to, and also pressure originating in concern. And parental support can include making appointments, driving, financial support, and help with medication adherence. Families may not always have the skills to know how to support their children in these situations, and family therapy can be an effective intervention. One example of this is community reinforcement and family training. CRAFT works through the family members of unmotivated individuals who use substances to influence them to enter treatment. CRAFT focuses on improving family relationships and enhancing the self-efficacy of the non-using family member. In this CRAFT study, they studied 36 initially treatment-refusing youth who were engaged into treatment via their CRAFT-trained family members, and they explored these youth's reasons and feelings about entering treatment. Those youth reported that the most important feelings they had about entering treatment were hopeful, relieved, happy, glad, relaxed. And the most important reasons for entering treatment were, I'm tired of living the way I have been. I want to stop using drugs. I want to cut down my use of drugs. I want to feel good about myself. I want help. We know that not all youth have family who are actively involved, or sometimes the substance use has pulled them away from the influence of their family. Who provides the external pressure or extrinsic motivation for these youth? We know that structure, boundaries, and safety are vital in times of uncertainty and danger. Can secure care provide those safe boundaries? I'd like to draw from the experience in Alberta. There are various different secure care legislations and programs across the country, but I'd like to briefly describe the legislation in our neighboring province. Alberta's legislation is the Protection of Children Abusing Drugs program, also known as PCHAD. The law took effect on July 1st, 2006. A legal guardian can apply to the court for a PCHAD protection order for their child under 18. This protection order means that the child will be taken involuntarily to a protective safe house for up to 15 days for detoxification, stabilization, and assessment. Alberta also has the Protection of Sexually Exploited Children Act, or PSECA, that provides protection and specialized services to children who are sexually exploited through their involvement in prostitution. Although this is not a peer-reviewed document, the 2009 summary of the PCHAD services reported that immediately after discharge, more than half of the youth sought some type of help or support service from some provider. 3 months after discharge, 37% were receiving some type of service. Fewer youth used alcohol, tobacco, or other drugs 1 month and 3 months after discharge. 23% of youth reported not using any alcohol, tobacco, or other drugs 1 month after discharge, and 30% at 3 months. 26% of youth who used alcohol, tobacco, or cannabis said that they used less 1 month after discharge, and 23% of those who used alcohol, cannabis, or hallucinogens said that they used less 3 months after discharge. In addition to their many other programs, Hull Services in Calgary provides secure services. I spoke to a couple of people who work or have worked in the Hull Secure Services, and they both shared a similar sentiment, which I thought was reflected in this quote from the 2020 annual report. There can be a misconception that it is a kid jail, that bad kids go there to be locked up and serve time, end of story. In reality, for most kids, it's the opportunity to begin to rewrite their story. At BC Children's Hospital, youth are presenting to the emergency department after life-threatening overdose once every month or two, and the staff work to provide appropriate stabilization care. The goals of stabilization are clearing of mental status, to provide meaningful medical, psychiatric, substance use, and psychosocial assessment, discuss and offer opioid agonist treatment, engage youth, parents, guardians, and community resources, and use motivational interviewing. Harm reduction, to evaluate and treat concurrent medical problems, and to develop a realistic discharge and treatment plan. At least 50% of patients are admitted voluntarily. Of those who are involuntary, many are certified primarily for psychiatric concerns, in addition to the substance use, not the overdose alone. Some are not admitted at all. Many of the patients are successfully connecting to voluntary services in the community after discharge, including OAT, counseling, and residential treatment. However, pediatricians worry that there is often a dire lack of services for these youth and their families after they are discharged from the hospital. We know that adolescence can be a risky time, especially when substance use is involved. And even though providing stabilization care for patients can be vital, secure care does not equal recovery. And in fact, treatment does not equal recovery. But stabilization can open a door, and it can be an opportunity for us to provide supportive care and connection. And for those youth to have time to gain clarity, set goals, and get support towards working on those goals. We can try to use external pressure to bring youth into treatment, but we can't force them to actively participate and engage in treatment. And we can't force lasting behavior change. In a study of justice-involved youth in the US, youth expressed the belief that the way in which probation tackled a youth substance use problem was not effective and could lead to increasing use. And a quote from a 16-year-old youth reads, "It doesn't help. It just makes everything worse. You can't stop someone from doing drugs if they want to do it. You can't stop them because then it makes them like sneakier and it makes them want to do it more." We may not be able to make youth change their behaviors, but can providing a period of stabilization give caregivers an opportunity to engage the youth and help connect them to family, community, and other resources? Engaging a youth in a caring, compassionate way can have a positive impact, even in an adverse situation. I'd like to read to you a couple of quotes from the recent report by the BC Representative for Children and Youth. "Having an adult taking interest in me and actually caring about my mental health, I didn't really exactly have much of that, other than my grandfather. Yeah, there were some good people in there that were friends. They were helpful, supportive, genuinely concerned for us. Instead of making me feel like I was their patient, they made it feel like it was teamwork, working together to get out of this problem situation. I wish that doctors and nurses would treat more of their patients like that." Stabilizing a youth is only the beginning. Often much of the responsibility to make changes gets put on the youth, but how can we be more effective in supporting these youth, or any of our clients for that matter? It's not just what we know, but how we are with people. Clinician behaviors are important determinants of client motivation. Research in client motivation showed that clinician hostility and confrontation results in withdrawal, lower involvement, distancing, reactivity, and resistance. It's important for us to be aware of whatever messages we're sending out, because hostility is not always overt, but can be unconscious and unintentional, and verbal tone can influence engagement. Another study reported that random designation of certain clients and telling the counselor that they had a good prognosis influenced counselors' views of those clients. And a therapist's view of a client and the prognosis affected client motivation and outcome. Clients' perception of the therapist wanting to help increased commitment to continue treatment and willingness to be influenced. Empathy. There are many definitions of empathy. Empathy can look like respect, warmth, caring concern, supportiveness, sympathetic understanding, commitment, and active interest. And in a study examining therapy cases and therapist styles, empathy was predictive of a therapist's effectiveness with their clients and the client outcomes as being rated as successful. And finally, some of the most successful motivational interventions reported have involved continuity of contact between client and treatment provider. In conclusion, youth are more likely to engage in impulsive decision-making and risky behaviors. Substance use impairs decision-making capacity. We can't enforce behavior change, but we can try to engage youth and help connect them with family, community, and resources. We don't know if secure care works, and there is also a serious risk of doing nothing. We need to support vulnerable youth with a comprehensive system of services, which goes beyond Bill 22. And for those youth who fall between the cracks, can secure care provide a safety net? I'd like to send a heartfelt thank you to a number of people who have supported me in today's presentation. I have references that are available if you are interested. And I am available for comments, feedback, questions. But before I do, I'd like to share some information about the 24/7 Addiction Medicine Clinician Support Line, which provides live, in-the-moment addiction medicine support to physicians, nurse practitioners, nurses, midwives, and pharmacists in BC while they're treating patients.
Hey, well, thank you, Hella, for thought-provoking presentation and laying out the sort of considerations and arguments on both sides, as well as contextualizing that with as much research as you could. Really appreciate all the time and thought that you put into this presentation and topic. And yeah, so we'll invite questions from the audience now. As I said previously, please feel free to type your question in the question box on GoToWebinar. We can also make space for folks to unmute their microphones. Actually, I'm not sure if that's a possibility on here. It might need to be just in the question box. We do have one already from Zhang Vo. Is regarding the question of overdose after secure care. is there any evidence from the fentanyl era in a healthcare setting, not just justice or jail? Some argue that the drug supply is so toxic and unpredictable that people who use cannot rely on their tolerance in the fentanyl era.
Well, I'm not sure how to answer that question in terms of the research. Anecdotally and from some qualitative papers that I've read, it does seem more and more common that people might need to use naloxone, several times to see if that has any effect. And that you're right, the toxicity of the drug seems to be greater. But can you specify the question that you had? Maybe you could repeat the beginning of that, Cody.
Yeah, it says, regarding the question of overdose after secure care, is there any evidence from the fentanyl era? So, I think sort of the last 4 or 5 years from the healthcare setting, not just justice or jail. Just saying that some argue that the drug supply is so toxic and unpredictable that people who use cannot rely on their tolerance in the fentanyl
Mm-hmm.
era.
Mm-hmm. Mm-hmm. Well, I would agree that they can't rely on their tolerance. And I think just in terms of the secure care and stabilization care in particular, I think a main goal around stabilization, one of the main goals is not just to engage, but also to be able to talk to the youth in a kind of more calm setting about the risks and hopefully to be able to get them onto some opioid agonist treatment or do some more education around harm reduction. And as Dr. Vo probably could also speak to, it sounds like at BC Children's they have been successful in being able to engage those youth in that way.
Great, thank you. The next question is from Lindsay Bertram. She says, did any of the studies explore whether youth felt that being forced into secure care was a traumatic experience?
Well, because as I mentioned, there is no peer-reviewed research in Canada about secure care in particular, but in the recent report by the BC Representative of Children and Youth, and this report was not particular specific to stabilization care, but just about children and youth who were certified in hospital, there absolutely are reports of that being a traumatic experience as well.
There weren't any sort of investigations of youth's perspectives in other provinces where they do have some form of secure care legislation?
Well, I honestly couldn't find any. I know there's currently being some qualitative research being done now through BC Children's Hospital, but those results aren't out yet. But I know that there's data being collected right now through the at-risk youth study.
Okay, thank you. Terry Leshko asks, how do we get a copy of the references? Would that be just to email
Yeah, you could email me.
Do you want to flip back to your slide that has your email? There we go.
Yeah, I'm happy to share those references. Mm-hmm.
Yeah, so that email is just hella.lee@vch.ca. So HELLA.LEE@vch.ca. Sue Ward says, thank you for your presentation. Did you look at various models of family therapy other than CRAFT? And if so, what did you find?
That's a great question. There are definitely, I didn't do an extensive study about the family therapy interventions. The reason why CRAFT popped up is it is a study that I've kind of heard about, not this particular study, but this intervention quite a lot through the research, the kind of quick scan that I did. And so I know that there are other models that also can be effective. And I think the key around involving families is also giving them education and support, not only around knowing how to cope, but also how to be in a relationship with their youth and support their youth in engaging treatment and in family therapy during treatment. So craft is absolutely not the only intervention, but it's just one that I'd come across quite regularly in the reading.
Ryan Tanner says, based on what has been presented, the success slash failure of secure care seems to hinge strongly upon the other service providers connected, i.e. how clinicians, police, etc. respond will impact how successful secure care may be or not be. Should addressing these systems take priority over secure care?
Well, I think how we engage with youth and any clients for that matter, or patients, is always vital in how things turn out. Um, but I think also, in the crisis of those moments where a youth actually presents with a serious overdose to the emergency department, I think that the physicians have felt like they need to find a way of creating some stabilization and safety, and also, find a way of engaging. And I think engagement is an important part throughout all of the, treatment and services that we provide. And I don't think secure care or Bill 22 is a final solution at all. I think it may be one piece that can be vital, an important intervention in those acute periods of crisis. But I think we absolutely need to put a lot of energy and develop the resources, not only in the services that we provide, but also in just how we as clinicians work with youth.
I have another question here that's come in two parts from Elise Durant. She says, I would like to ask about taking an anti-racist lens. As we know that hospitals and other systems have reinforced racism and can re-traumatize youth, how do we balance involuntary admission in this? And then the kind of follow-up piece was also, most notably, many people would argue that hospitals across BC are not calm settings for youth who use drugs to receive care. So kind of how do we address the sort of structural issues that might be in place in some of these institutionalized settings, hospitals in particular?
Yeah. Well, I think that whole notion of a hospitalization being traumatic, I think absolutely it would be an extremely frightening experience for people, because of the circumstance and because of, for a number of reasons. But I guess the argument is also, is it not traumatic for people to not get the treatment that they need? Absolutely, it could be scary, but are there ways that we can also engage with those youth in times of crisis to to be comforting, to be reassuring, to do whatever we can as care providers to provide as a warm, caring atmosphere as possible. And from the treatment providers that I've talked to at BC Children's and elsewhere, I know that they go to great efforts to try to engage the youth, whether that's just in their bedside manner, or in getting food that they enjoy, and trying to kind of bring them whatever comforts that they can. And I guess another part of that is, do we just not do the secure care because we're not doing a good job of it? Or is there a way that if we do end up implementing more kind of secure care, that we can actually do it better and in a way that can come across as being caring? And I guess the second part about the providing I think, what did you say, kind of a non-racist perspective? I know that is also an argument that's come up quite regularly. But again, that whole part of, is it, do we not actively intervene in these situations for fear of being, I'm not sure how to best word this, but it not being culturally sensitive or re-traumatizing. But again, that whole argument of, if we don't do anything, what is that like for people to feel like they don't have the support? And how do we kind of draw in different cultural, whether it's Indigenous elders or community stakeholders, to also be able to advise, connect, and provide that resource for those youth?
Okay, thank you. This is obviously a hot topic. There's way more questions here than we're going to be able to get to, and I see it's gone 1 o'clock. Are you okay with fitting one more in, and then we'll wrap up?
Sure.
Okay. This was Heather Fisher says, what actions need to be taken now to help move the secure care legislation forward for those youth who fall between the cracks and are at high risk of dying from fatal ODs in BC? Another part to that, she says, do we know how many of the 17 youth who died last year were Indigenous?
I don't know.
How do we move this forward? And yeah.
I don't know the percentage of youth that were Indigenous in the 17. And it's hard for me to answer how we move this forward, because there are some strong and vocal and really valid arguments on both sides. And it seems like, this issue has been raised time and time again, and often ends up in a lot of debate. As a social worker and a clinician, my interest would actually be to go out to the other provinces, actually spend some time in the other programs to get a really firsthand experience of what that's like for youth. And because I think there are a lot of questions that we have, and I think it's absolutely important to be very cautious. And even though there isn't peer-reviewed research, I think there's a lot of experience that people have, clinicians, youth, family members, and it would be great to kind of actually go and see what that experience is like, and help us to have a better informed decision around that.
Okay. Great. Well, thank you, Hella. Really appreciate all the time and energy and work that you put into this presentation again. And thank you to all of you that tuned in. I saw there was, I think, over 150 in the main part of the presentation. So yeah, thanks for all of your interest. And please keep an eye out for our next poster. I believe the next Addiction Social Work What's New talk we have is not until June. But thanks for your attendance and have a great afternoon.
Thanks for joining.